Good afternoon, ladies and gentlemen. My name's Stephen Took, and I'm the Commercial Director of Tookie Limited. And thank you very much indeed for coming to listen to our presentation today. I'm very, very appreciative of the company that have joined me today to co-present, and I'll be introducing them individually before they make their individual presentation contributions. But I just want to say thank you very much indeed, and thank you to you too. Now, before we start, can I just ask for a little bit of interaction, participation? Could you all raise your hands if you have a mobile telephone? Super. Could you raise your hands if you use Twitter? Super. So those are the people I'm talking to at the moment, but I'll try and encourage the others. What I'd like to do today is to introduce Tookie Limited, but also to introduce our Twitter account, which is at Tookie Co. And we'll also be introducing our brand, which is #ALifeMoreNormal. So if there's any questions you'd like to ask, if there's any information, if there's anything that you like in terms of the presentation that you find interesting, then please use the Twitter at Tookie Co and the #ALifeMoreNormal. And at the end of the presentation, we'll have a look to see if there's any tweets that can be used in our question and answer. And besides which, of course, all of you that have just followed Tookie are now our followers, so thank you for that. Okay, so today we're talking about how Tookie Limited delivered a life more normal using pioneering innovations for patients and lines. So here's my contact details, and the slide, the first slide also shows our key partners, the Institute of Health Research, the NIHR. Tookie Limited has 4 products currently on the NHS supply chain, and we're delighted that last year we won the Innovation Award for medical devices through the Northern Powerhouse Medilink Awards. And also delighted that this year we're partnering with the Yorkshire Humberside Academic Health Science Network in the Partnership Awards for the HSJ, the Health Science Journal Awards for medical devices. So my co-presenters today is Mr. Ross Craigie, Heather Lambert, and Dr. Syed Ahmed. Sorry, Dr. Heather Lambert, Dorothy Peacock, Maddie, and then I'll be calling upon Nat Mills from D4D and Titch. So who is Tookie? Tookie's an award-winning innovation company, and we develop products for patients that are fitted with lines. We started with oncology and renal. We've migrated now over to nutrition. We're looking at respiratory, we're looking at gastro, a whole raft of patient group areas because there is an unmet need for lines to be secured safely so that patients can be active if they can. Parents can be reassured because the child is safer wearing a Tookie product. And importantly for ladies, especially in the mixed renal setting, is for modesty and dignity, which we'll hear about as we go through the presentation. So the products, what do they do? A life more normal is underpinned by freedom, independence, and dignity. Reassurance, it's confidence in activity. We have patients that wear our Tookie products and they're back at school, they're back in the nursery, they're playing football, etc. Things that can be achieved on an everyday basis. So they're all patient and clinician-centered designed so that we in Tookie listen and then incorporate that information into designs, and we go back time and time again until we get it right. All our products are CE marked and commercially available on the NHS supply chain. So just going through very quickly, these are the product patient group areas, and I won't go back through them again, but we at Tookie want to provide patients with products that are available in the hospitals, but it's equally important it's a transition to the community where perhaps the parents and the individuals themselves are feeling less confident because they're away from the care team, and it's in a more vulnerable environment. So Tookie's innovation pathway, I'd just like to talk off the slide for a few minutes. This is our characterization, our innovation pathway in reality. So here I am down the bottom left, this is Tookie, and we're looking for our point of entry, how do we find the innovation pathway? And at this stage, what is the innovation pathway? And I was very fortunate that I met Nat Mills from the Titch Network and Devices for Dignity very early on, who looked at the Tookie solution and breathed over it to give me a decision as to whether it was something that they thought might be in time suitable for a solution to an unmet need. And I'm delighted that Nat has provided me ongoing support for the last three and a half years. And thank you for that. Absolutely invaluable, where to find what you need next. So we go to the NIHR, the National Institute of Health Research. We ask them for support and guidance, and you can see the pathway then unfolds in terms of the Academic Health Science Network. We work with 5 academic health science networks around the country to help us with the spread of adoption. Another organisation, MedConnect North, we were supported to the hilt by Rachel Morris, who's sitting to my left here, who has helped us as a conduit between industry and the NIHR, where we've had 2 products commercially designed and developed through Newcastle and Sunderland. And then we go on to NICE, the focus group. Medilink help us with the value proposition, and we're getting ourselves market ready towards the NHS procurement and eventually to NHS adoption. New product development. So this is a flavour of what's coming through in terms of Tookie. This is a product for PD catheters, peritoneal dialysis, also a patient with a gastro button. And this is really about trying to stop her little hands trying to find the catheter to pull, or the Mickey button to pull out as well. So it's about saving the family's time, it's about saving the NHS money, and it's about saving the clinical time to reinstate and revise things that really could be prevented from not being pulled out. Neonates, this is a product which I really like, which is being designed with Heather's team up in Newcastle. We call it the swaddle because it really does swaddle the child. This one is an adult for nephrostomy. There's a gentleman, elderly gentleman, who is fed up with his drain bags, which he lies on when he sleeps. Equally, he has a belt, and as the bags fill, they start to slide down. So we're trying to stop gravity from taking over, but also providing him something comfortable to wear, but also to provide dignity. This is an interesting project which is incorporating biosensor technology, and this is a collaborative partnership with these innovators here, which includes the Children's Hospital in Sheffield, the University, Edinburgh University, and the NIHR SIP Tech, which Nat will talk about very quickly a little bit later. This is what we're trying to achieve through research, through grant funding, which is an autonomous ventilator trolley to carry the ventilator pump, and it follows the patient using biosensor technology. So the sensor's built into the Tookie vest, which is the garment being worn by the child, stabilization of the tube itself on the front, which is a quick release mechanism as well, but the trolley will be always at that distance away from and following the patient by virtue of a proximity sensor built into the trolley and the garment itself.
So as Steve said, I'm Ross Craig. I'm one of the paediatric surgeons in Manchester. My subspecialty interest is surgical oncology. So that's how I became involved with Tookie and the vest. So about 1,400 children a year in England under the age of 15 are diagnosed with cancer. And as you can imagine, a central line is integral to their care, which is the same as adults. The difference between children and adults is, well, I say adults do as they're told, not always, but you can imagine that children either don't understand the importance of this line, or actually some of our older patients come to resent it. although a child's got cancer, they're still a child. They want to play with their siblings. They want to go to their school friend's party. They want to do all these things that children normally do. The problem with that is that increases the risk of the line being pulled out prematurely halfway through their treatment. Now, there are devices out there for adults, a lot of paediatric practice. It's things that have been used for adults that we just take into paediatric practice. So a lot of the things that, and I use the term loosely, secure lines in adults, they don't actually secure them. They allow an adult to put them in a comfortable position. But that's certainly not childproof, and it doesn't stop the child pulling at the line or bringing it out. So in 2019, surely we've got something to stop that. Well, amazingly, we don't. If you come probably most on paediatric oncology wards around the country, the children are running around with homemade bags, usually by the grandmother or something like that. It's interesting, we tell children not to put things around their neck, then they go into hospital, we put this bag around their neck and tell them to run around with it. The other thing that some of the smaller children, the family use, are like big tubey grips around the chest and things like that, but that's clearly unsatisfactory in this day and age. So why security for these lines important? Well, you see these families day in, day out. I have absolutely no idea the stress and anxiety that must come with the diagnosis or being told that your child has cancer. And understandably, the families see this line as integral to their child's treatment. That's the only thing, the medication to that line, that will make their child better. So the families need that reassurance. And actually, I think we sometimes don't give children the credit for what they understand. A lot of those children also need the reassurance that that line's secure and they're going to get better. We did an audit in Manchester, and it's probably reflected throughout the country, that actually in our oncology patients with central lines, approximately 10% of them came out prematurely and required replacement not as a result of infection or things like that, but being pulled out. So what's the effect of that line being pulled out? Well, clearly it affects the patient experience. We want as seamless as patient journey as possible, especially with a child diagnosed with cancer. It could potentially cause a delay in treatment. Now, that's probably not clinically significant if you delay giving the chemotherapy by 1 or 2 days, but you can imagine the poor family, if, as sometimes happens, if the child doesn't survive their illness, the family, you can imagine sadly, if they had had their chemotherapy on that day, would it have been different? We know it probably wouldn't, but that's no reassurance to that family. It's an unscheduled admission to hospital. So I think if you speak to any family who's in and out of hospital with a disease all the time, they really cherish their time at home. So 1 or 2 extra days in hospital when you're there the whole time is actually 1 or 2 days too many. Also need a further line inserted. Now, you or I in adult practice, you go in, bit of local anaesthetic, the line's put in. Children, it's not fair to do that. A, it's not fair, and B, it's not safe because they'll be moving around. So it's performed under general anaesthetic, so it comes with that period of fasting, admission to the hospital, and we're exposing the children to risk of general anaesthetic and also of a further line insertion. Although very uncommon, line insertion has actually got a noted mortality with it, so if you can avoid that, all well and good. There's also the financial cost of premature fallout, not only to the family but to the NHS. Admission to hospital, we always quote £400 a night in bed. Children's hospitals are probably a bit more expensive than that, actually. Again, it's an unscheduled admission, so the child will probably go on the emergency list. Anybody who works in a hospital will know that the emergency list is absolute carnage. You can't, confirm a time at all. Patients might be in 2-3 days that they didn't need to be. There's £1,500 before you've even started. Theatre costs, so certainly in Manchester, it's about £8,500 a day for one theatre to run. So morning, you're probably talking 4 and a bit thousand, probably do 3 lines in the morning. The equipment itself, so Hickman line's £180 to £200, so just that little tube of plastic, yet again, it's more cost. And we've got to remember, it's always very nice when you're a professional, because if you take time off, you get paid and things like this. A lot of self-employed people who don't get paid if they don't turn up to work, so that trip to the hospital has cost them. Travel costs as well, so paediatric oncology is a regional service, it's not a local service. So patients don't live within a couple of miles of the hospital. So in Manchester, we cover from sort of mid-Cumbria down to the Cheshire-Staffordshire border, which is a huge area, 2.5-3 hours drive some of these patients have from rural Cumbria. So evidence is the key. This is where I work. It's the biggest children's hospital in the UK, and we put in about between 500 and 600 central lines a year for all comers, it's not just oncology, but we're starting a prospective study in Manchester just on oncology patients who are having a central line inserted. We'll be approaching every family, and I suppose the advantage one has when one speaks to parents whose child has cancer is that they're usually already being discussed about trials and things like that with regards to treatment. So somebody's already done the hard work about introducing trials to the family, so that certainly makes my life easier. And what we're planning to do is aim to recruit 100 patients, follow them through until the line comes out for whatever reason. So our primary outcome is obviously fallout rate. We've also got a secondary outcome of line infection rate, and people might say, well, how can securing a line reduce the infection rate? Well, as I alluded to in the first slide, there's no satisfactory way of securing the line. So you'll find some families tuck the line into the nappy to keep it secure. It's not the cleanest place in the body. And secondly, you'll sometimes walk in the ward and see the children chewing at the end of their lines and things like that. So it may be that securing the line reduces the infection rate. Once we're through, we're hoping to publish our findings. So watch this space.
So I'm Heather Lambert, I'm a paediatric nephrologist up in Newcastle, and I work with a very big team, but these Yinton Say and Jenny Booth are the main people that we've been working with Tookie on these vests. The message I've got for you is the same really as Ross has said. Disease is different, but the underlying principles are the same. There are about 1,000 children in the UK who have renal replacement therapy, and each year they're joined by 120, 150 new patients. Most of them are born with kidneys that didn't form correctly, and others develop kidney disease at a later stage. And whilst we always aim to transplant them, many of them will need dialysis before that. There is no cure for renal failure, it's lifelong treatment. So everything that we're talking about goes on for years and years, not just a short period of unpleasant treatment or inconvenience. This is lifelong. 3 forms of treatment, and if you don't get transplanted or transplant fails, then dialysis is the mainstay of treatment. This is, pointing to the wrong thing. This is hemodialysis, in which blood is removed from the child and is cleaned by passing it through a filter, and it is returned to the child. In order to have hemodialysis, the child has a double lumen line which goes in through the chest wall into a big blood vessel. In peritoneal dialysis, the cleaning and the filter is the peritoneal membrane, which is a membrane which lines the abdominal cavity. And fluid is passed through this silicone tube into the abdominal cavity, sits there for a period of time, and then is emptied out. In addition, children who are on dialysis often need help with feeding. This child has got a tube down their nose into their stomach. This is a tube going directly into the stomach for feeding. We see a lot of babies and infants who have renal replacement therapy, and we can't, partly that's because we can't transplant them until they are big enough to be transplanted, and that's about 10 kilograms. That can take us 2 or 3 years, and in the meantime, they suffer the problems of their renal failure, as well as problems with their dialysis access and repeated hospital admissions. Let's just think for a moment, what is normal childhood? Well, normal childhood is being out with your mates, playing. It's eating and drinking normally. It's going to school, it's learning. All of those things are affected by being on dialysis. We know that children who are on dialysis have a much worse quality of life score than children who do not have dialysis. And if you even compare them to other children who have a chronic health condition, children on dialysis have a much worse quality of life score. So we need innovation to try and improve things. What can we do? Well, we can we can dialyse them sufficiently to make them feel well, we can feed them to grow, we can get them out of hospital, get them home, and we can encourage people not to overprotect. You mentioned the devastating effect of a diagnosis of cancer. It's the same with renal failure. The effect on families of telling them their child has this lifelong condition of renal failure and needs dialysis. I don't think any of us can underestimate what that means to the family. And again, just like the central lines you were talking about, they become very obsessed by the dialysis lines, quite rightly. That can result in so much anxiety that children are overprotected. We've always been looking for solutions, and a little bit of a historical perspective here. This young man, well over 30 years ago, was one of the first patients in the UK to have peritoneal dialysis. He's now adult, married, children of his own. At the time we dialysed him, there were no automated machines or anything. You simply took a bag of dialysis fluid, poured it into the abdomen, left it there for a few hours, and then poured it out. Now this little chap only needed a few 100 mils poured into his little tiny abdomen. The only bags that were available were adult bags, a litre or more. So poor chap had this great big bag of fluid that he was still attached to all the time. So the solution, as ever, came from the family, and Granny knitted little woolen hats for the bag to go in, which were attached to the romper suits and often matched the romper suits wonderfully. Our collaboration with Tookie has been family and patient focused, in exactly the same that this was patient focused. The Tookie vest has been designed to try and preserve the integrity of central lines and what we're currently working on, peritoneal dialysis catheters, and doing that by holding these tubes securely. And it's also aimed to try and reduce the anxiety and overprotection of schools and families and nurseries relating to children who have dialysis catheters. So I've been very pleased to work with Tookie, and we have to mention the number of families that have worked with us, both in focus groups and individually testing out the prototype, making comments. They put a huge amount into helping us, so thank you.
Okay, so thank you very much. My name is Saeed Ahmed. I'm a nephrologist. I'm an adult doctor, not a pediatric doctor so far. And so, as you can see the theme, we look after about 35,000 patients on dialysis programs. And we are set by the national guidelines to have patients on something called a fistula for dialysis, but I'm afraid a significant amount of people are on lines, as we've been talking about. So these lines sometimes have to be put in as an emergency. So the top left on your side, or top right on your side, is a picture of a line I placed in a gentleman after about 1 minute after telling him he needed dialysis. So you can see sometimes we can put him in really fast, and he was obviously shocked by all this. And that was his first, journey towards connecting him, in that case, through this line to this machine here. And that's what we spend doing for those 35,000 patients. Now, majority are not on lines, but a significant number will be on it. And these are the kind of lines we deal with. There's single lumen, double lumen. And the issue is, as much as fallout that's been mentioned and displacement, this is crucial how we place these in to get adequate dialysis. So from a technical perspective, it is important we have that line placed correctly. And I do about 100, 120 lines a year, and we do take a lot of time to place them correctly in the patient. So we do take a lot of care of them. So you can see how maybe a little bit annoyed we get when they fall out and patient turns up to their dialysis session after the weekend. I don't know what they've been doing with it, but they turn up and it's either fallen out or displaced, or it's in a carrier bag usually. And so that, you can say, a little bit of a heart sink because you didn't plan for it, but that's how life goes. So we have so many patients on dialysis, and this is the technical aspects of it you've talked about, and this is the particular line we're doing. So some of the patients will explain this to you, that we're placing the line in the heart itself to get good, adequate supply of blood that we can then take off to the dialysis machine. And we did a little study to look at this placement of these lines. And in this case, is it actually a 2-lumen line? That's a single lumen line. It's a 2-lumen line, so as many of these procedures will take about an hour and a half to do. And that's the perspective of putting it in. But I'm afraid the body habitus of our patients, they may be small in the pediatric world, but they get large. Sometimes even pediatric patients are large, but we have either large adults or small adults. We have people from about 50 to 40 kg all the way to 150 or even 200 kg, all on a similar type of line. And there's maximum sizes as well. And what we've noticed over time, this displacement issue is very pertinent. So these lines are placed, there's something called a cuff here that's placed there, and it's the movement of those cuffs. And you may not notice it until somebody does a dialysis session, but we notice this on our monthly parameters. So placing the line is important. So that was the solution, and I didn't know the answer. And I went to the patient and saying, look, these lines keep moving. What do we need to do? Tookie somehow turned up with the help of Rachel at the prime time. And then we had a lot of patient discussions. I can't remember now, it's up to about 4 or 5 or 6. And it was interesting. I was in the background watching the patients come out with the ideas of how to stop and explore the different parameters of how to stop this happening. Now, obviously the solution was helped by all these people in the background, but it was nice to see in a small department like mine, the patients driving the change, us facilitating the change and we adopting the change. And in a department where maybe research wasn't our focus because we're a hard-working day-to-day mill of turning patients over, it's really become an interesting idea over the last 3 years. We have changed and flipped, and research now is core to our belief, and also the patient focus of this new word which I learned through these 3 years called co-production. So the production of, from the patient's perspective with ours together, has come up with a solution, and this is one of those solutions. We also got a supermodel out of it, which is always helpful in this case. So this is the product that you've seen already, and obviously Steve's done his marketing bit. I didn't know anything about this, but this is one of our patients with the vest itself. And that's now, as Steve says, available to our patients to use, and it helps me to understand that when I do place one of these lines in, we can offer this service to the patient. And obviously we'll see Dorothy's perspective from that in a minute. I'm going to go on to this particular bit. Now, this is a surprise slide, which I don't think Dorothy is expecting. Now, Dorothy is the next patient, but as you can see, she's her National Award for Non-Medical NHS Using Heroes Award, which she has just been having a certificate for here. She's been nominated and shortlisted, so I'm going to present live on stage. And no long speeches. You can't, it's not Oscars, but you just come. Is she allowed to say a word or two? Just a quick.
What?
Yeah. Just,
Wow, obviously, this is fabulous. Well, I didn't. To me, I haven't really done anything towards Tookie just doing my normal thing and turning up. But I'm very interested in Tookie and what it does. And honestly, this is just, I don't deserve it. The whole of the Tookie team deserve this. Thank you. Right. The brain is a wonderful thing. It starts to work from birth, never stops until you have to stand up and make a speech. And that's me. My name is Dorothy, and I am a former dialysis patient at Sunderland Royal. After many years of hypertension, my kidneys had been deteriorating to the point where their function was down to 5% usage. There was no other option at this time but for me to have dialysis. It happened so quickly that Dr. Ahmed said, you have to go on dialysis straight away. So in 2016, after failed attempts with an arm fistula, I was fitted with a neckline catheter. My treatment was, as everyone knows, in 4-hourly sessions, 3 times a week on a dialysis machine. Luckily, there were no problems. My main concern at this time was the security of the line that we've all been talking about. The reason being, if it became loose or infected, it would mean another procedure to have it refitted, causing more internal scarring and distress. Although the lines aren't uncomfortable, where do you store them when they're not in use 24 hours a day? This is where Tookie came in. 2 months into my treatment, I was introduced to Stephen Took. This is when I first learned about brand Tookie and Tookie products. We spoke at great length about his visions for the design of a vest for renal patients with a neckline. His enthusiasm about the vest was contagious. The idea being that in the future, dialysis patients everywhere would have a chance to have all their concerns of having a neckline taken care of both night and day. Over the coming months, many meetings took place with renal staff and the other patients, all with different needs, but who would all benefit from wearing the Tookie vest and to be able to adapt their own lives and needs if necessary. It has been an excellent experience for me to have had an input into the journey of Tookie vest, how it would be of help to neckline patients. The discreet design of the vest is also extremely important for female patients, as it retains their modesty in a mixed ward. The design also helps the nursing staff with the lines and the open wounds being on view. They are easy to access and avoid clothing being disturbed, making their daily routine much easier. I hope that Tookie's continuing success far and wide will bring security, privacy and freedom to all patients, giving them a future worth living. Thank you for listening.
So I'm Maddie. I've known Steve for nearly a year, I think. He hijacked me at UK Kidney Week with Sid. That is actually what happened. And I hadn't heard of the work that Tookie are doing, but actually it very quickly became very clear to me that this is something that really has been missing for kidney patients, which is my particular interest, but for patients more generally. And my passion and the message that I've always put across in my own life is that if you have any kind of health condition, your life should still come first, and your health condition needs to be managed around your life. And particularly for sort of more serious chronic conditions, I know that often doesn't happen. So I am a businesswoman and an entrepreneur. I'm a consultant. I do various different things. I grow new businesses. I consult for other businesses. My background is in investment banking. I'm an adrenaline obsessive, so I'm a skydiver. I ride racehorses. I love adventure. I also am very passionate about advocacy, peer support, mentoring, and getting actively involved in the healthcare world. And the reason for that is because I've also been on kidney dialysis for 21 years this year. I am going to have a party. I was diagnosed with an autoimmune condition when I was 13, which is very aggressive, didn't respond to any treatment at all. My kidneys failed when I was 14. And I can't have a transplant. I had an attempted transplant, but unfortunately my condition came straight back and was very aggressive again. So I'm on dialysis potentially for my whole life, certainly for the very long-term foreseeable future. And I think as a teenager, when you're told you need this machine, otherwise you are going to die, I don't think there are many other situations that can really compare to hearing that message as a young person. And having already been through a year and a half of very traumatic intervention and treatment and living in hospital and everything, my whole life went into meltdown. I've considered myself to be very lucky because I was at a very good school and I had a wonderful supportive family. So I was coming from a background where I was already quite well educated and well informed. I had a voice. I was confident enough to speak up for myself, and my family also were able to do so. So as a teenager, suddenly being plunged into this medical environment, I was actually probably in the best position I could be. And I'm very aware that not everybody has those ingredients in their life. And I feel incredibly lucky that my dad is a doctor, so I have a healthy disrespect for all doctors, which my consultant, I drive him mad, but I think it's good because I always had a partnership with the care team right from that very young age. And all those ingredients really tied together to give me a very, very different experience from that which is perhaps typical for people on dialysis. And we've already talked a lot about how it is to kind of for a young person to suddenly lose your freedom. You can't go and play with your friends, you can't be at school. I certainly think when you start dialysis, you're given a list of all the things you cannot do. You cannot eat, you cannot drink, you've got to protect your PD line, you've got to protect your fistula, you've got to be here for appointments, you can't travel because you can't get dialysis, your life is just shut down. And I was never really prepared to accept that at all. And I was fortunate that the paediatric team at Guy's, who I was under, actually embraced the fact that I wanted to carry on living normally, and they did everything they possibly could to make that happen. So when I started, I was on PD. The first thing I did was get back on a horse, which everyone had a bit of a meltdown about because I didn't have a Tookie vest. I had a bit of tape, and I was riding this horse, and I was like, what if you fall off the horse? What are you going to do? I was like, well, I won't fall off. And fortunately, they didn't actually at any point institutionalize me and say, we're not letting you out anymore. But they helped me to create an attitude which is, what is it you want to do, and how can we be creative to make that happen around your condition? And psychologically, that's huge. Also, just in terms of your lifetime prospects, you know, that will help you be set for potentially going away to university when you leave school, getting a job, living independently, or being away from your parents, all things which actually young people on dialysis don't necessarily think they will ever get. And I know many young people who have never been able to get a job, still living at home, haven't got independence, haven't got an income. Their life is devastated by this condition. I did PD for 5 years. I had the transplant attempt. My dad, unfortunately, he donated to me and I trashed his kidney within 10 hours. So he did forgive me, but we kind of decided that transplantation is just not a sensible approach. And so I switched on to hemodialysis, and I actually do nocturnal hemodialysis at home. So I do 7 or 8 hours on the machine overnight while I sleep. So I get 30 plus hours of treatment a week instead of the 12 that people get in hospital. And I have to say, the foundation of care is critical. So before any of this other great stuff can happen, you do really need to be giving people the best quality care that you can. And one of my big passions is how do we get more patients to be encouraged to do home dialysis? Because as soon as you're dialysing at home, you're not tied to that minimum regime of 12 hours. You can do more treatment more often, more regularly, which means you can relax your restrictions around food and drink. It means you can fit it around other commitments in your life. It means you've got rid of all the travelling. So there's all sorts of amazing things that can happen, but you have to get that right. And I'm not going to say, you know, that's easy, but I really feel every patient should be encouraged and supported and coached until the point where they feel that they can consider home dialysis. And so that comes into things like the culture of care, what the clinical staff are saying, what are the role models of the patients seeing in the unit around them? Is anyone talking to them about self-care? Are people holding up home as being aspirational? Are you encouraging patients to get involved in their treatment? So, you know, what's this machine doing? Oh, I'll explain it to you. Maybe you could take your own blood pressure today and, you know, put that onto the form. And, you know, these little tiny things, it doesn't have to be a black and white decision. Oh, do you want to go on home dialysis? Because I think most people would say absolutely not. That's a terrifying thought. But if you get them interacting with their care over the course of several months, and then you say down the line, we could get you doing this at home, you're going to have a lot more of a success of actually getting that patient into that mindset. So there's all sorts of things that can happen in the unit, can happen when there are interactions with healthcare professionals. But I also think there is a huge part for innovative design, which is where the Tookie products and the Tookie ethos come in, because if they've actually looked at what people want to go and do with their lives, how can we make something that removes just that one element of worry and that element of risk? And, you know, we've talked about things about the cost. Having a central line inserted is horrific. I wish they'd give me a general anaesthetic, but if you're an adult, you're quite brave, and apparently you don't need one. So they're traumatising. And also, I mean, I have a fistula now, not a neckline. I have had a neckline. Not long after they put my neckline in, I went clubbing. I didn't tell anyone. And when I came back the next day, I said I went to a nightclub last night, and then they had a fit, and they said, well, was it really crowded and all these people? And I was like, yes. And it's these sort of things, but I didn't tell them because I was wise to the fact that they'd lock me up if I told them. So I tell people, it's better to ask for forgiveness than permission. But that is not, I wouldn't recommend that as a universal approach to all patients. And I'm very aware that some of my experiences are quite unique. But actually there are ways that you could make this a lot more of a more common experience for more people. I mean, you can see here my setup at home. So infection control is good with the cat, and I have my fistula with a very specific taping technique that I've developed for myself because I'm asleep while I do my treatment, and I actually cover the whole thing with a tubey grip once I've taped it up. I developed that technique for myself, knowing what worked for me and knowing how I could be comfortable sleeping. And my healthcare team were really supportive, and they said, yeah, we'll work with you to work out what works for you, as long as we know that it's secure and it's safe. And believe me, no dialysis patient is going to choose a less safe technique to secure their needles. So that's because they listened, they understood that I need to sleep because I work really long hours and I travel a lot on business. I can't afford to not sleep. They know that I'll be careful. The cat's not there when I needle, but he joins me afterwards and he keeps me happy. I think there's also an approach, things like restrictions. So on a dialysis diet, you can't eat potassium, you can't eat lots of phosphate, you can't drink much fluid. And so things like, fruit, veg, bananas, chocolate, coffee, all banned. Early on when I was getting to grips with this, my consultant said to me, I'm not going to say you can't eat pizza, because you're a teenager and you're going to go and eat pizza. And if I just ban it, you're probably going to go and eat more because you're rebelling and you're just angry about everything. So just be sensible about when you eat the pizza. Eat it the night before dialysis. Don't eat it every week. go and have fun and relax a little bit. I'm not going to give you a list of restrictions. And actually that was the wisest advice I ever had, because he helped me to understand it's all compromise. So if we can facilitate people to say, you know what, you want to go and do a certain activity, let's make it safe for you. Here's a product that you can wear, which is unobtrusive, is designed for the purpose. It stops you feeling like you have to kind of be different to everybody else. And then we can put your life first and you can go off and do the things that you want to do. That is such a good ethos to have. And when you're living with these kind of long-term life-threatening conditions, those things mean the world. And it can be the tiny things that make the biggest difference. And I do believe that if you can get those basics right, and if you can get that kind of approach to care right, and it's a partnership and you're empowering patients to take that ownership, you then put the health side piece to the side slightly. And I think someone who's living with a chronic health condition has a huge amount of skill and attribute and amazing facets of their personality that are there, but they're kind of buried under just coping and living with their condition. And if you can get the clinical stuff right, then you find people who have got huge strengths. They're massively resilient. They're really supportive. We have a wonderful community amongst the kidney patients where we peer support, advocacy, we look after each other. We have amazing young adult activity where the 18 to 35 kind of age group, we go on residential weekends, we do adventure stuff. The older ones mentor the younger ones. That it's the richest, most diverse group of people that you could ever have as your friends, because we've all been brought together by health, and health is a very levelling scenario. And so actually, if you can get some of this sort of practical stuff right, you end up giving people the chance to flourish and to thrive and to actually become whoever it is that they were going to be before their diagnosis kind of stopped them in their tracks. And for me, that has always been, let's push this as far as I possibly can. I've always tried to prove a point that dialysis won't hold me back, and eventually I stopped trying to prove a point and just realised I actually really enjoy doing ridiculous activities. But it's actually, I would never go back and switch off the button and say I won't have kidney failure now, because it's shaped my life unimaginably. And it's very, very empowering to think that something that was such a devastating diagnosis could become a positive force for good in my life. And I'm just very passionate about how do we help more patients to achieve that, regardless of their condition. And that's why I'm so supportive of the Life More Normal message, which I think is really powerful. So thank you.